You are sitting on the toilet right now, or you have been for the last few hours, straining with everything you have, and nothing happens. You feel it there, you feel the weight, you feel the pressure, but no matter how hard you try, it's as if your body has locked up completely and refuses to cooperate. You give up, go do something else, come back later, and find the exact same situation. Your belly is bloated in a way that isn't normal. The discomfort is present all the time, not as an acute pain that would make you rush to the hospital, but as that constant dull pressure that won't let you forget something is wrong. And as more time passes, you realize this won't resolve itself. There is something disturbing about this situation that goes beyond physical discomfort. It's the feeling of loss of control over your own body, the frustration of trying and failing, and that voice in the back of your mind wondering if something more serious is happening. If you are nodding while reading this, if these words describe exactly what you are going through right now, what I am about to tell you could literally be the difference between resolving this today at home or ending up in an emergency room tomorrow morning in a much more serious situation than it needed to be. Because what most people don't know, and what no one explains with the clarity the subject deserves, is that stool stuck in the intestine is not just common constipation that will pass with a laxative. It is a real physical obstruction that develops silently over days, progressively worsening while you wait, and which, when ignored, evolves into serious complications that an honest conversation today could have completely avoided. I am a physician, and throughout years of clinical practice, the thing that disturbs me most is not the severity of the cases that arrive at the office. It is the amount of time people waited before coming in. Days of increasing discomfort, sometimes weeks, suffering in silence with too much shame to talk about it, hoping it would pass on its own, taking laxative after laxative without understanding why nothing worked. While inside, the situation was getting progressively harder to resolve in ways that required increasingly invasive and uncomfortable interventions that could have been completely avoided with the right information at the right time. The stigma around this subject is literally hurting people. It is causing intelligent adults who are careful with their own health to make the wrong decisions, like taking antidiarrheals when what appears is watery diarrhea, which is one of the most dangerous mistakes someone in this situation can make for reasons I will explain in detail. Or straining repeatedly, thinking more effort will solve what effort isn't solving, when in fact each attempt is worsening the inflammation of the surrounding tissue and making resolution more painful and difficult. You deserve to have this information. You deserve to understand what is happening inside your own body with the clarity any other medical condition would receive without any embarrassment. And that is exactly what I'm going to give you today, without judgment, without euphemisms, and without leaving out anything relevant so that you can make the right decisions in the coming hours. Click subscribe now and hit the bell. And let's start with what is actually happening inside your intestine at this moment. The first thing I need you to understand, and which will completely change how you are interpreting what you're feeling, is that this didn't start today. It didn't start yesterday. What you are experiencing now is the visible result of a process that was happening silently inside your intestine for 3, 4, 5, or even 7 days. While you followed your normal routine, thinking you were fine, perhaps even going to the bathroom occasionally, and thinking you were evacuating properly. Here is what was actually happening. Every time you went to the bathroom and passed a small amount but felt you had finished, a portion of waste was being left behind. Not because of a failure of your body, not because of something you did wrong, but because the large intestine, when functioning below ideal capacity due to any combination of factors like dehydration, sedentary lifestyle, stress, or medications, cannot contract with enough force to ensure complete emptying with each bowel movement. This waste left behind on day 1 joined the waste from day 2 and day 3. And throughout those days, the large intestine continued doing what it was designed to do: absorb water. It absorbed water from the new waste arriving, and it absorbed water from the accumulated waste already there, until on the 5th or 6th day, this accumulated mass had lost practically all moisture, transforming from soft, malleable material into a hard, dry, bulky stone that the intestine simply does not have enough peristaltic force to move. Think of a completely dry sponge trying to pass through a narrow tube. It doesn't compress, it doesn't give, it doesn't mold to the available space. It stays exactly where it is while the pressure around it increases progressively. The factors that most consistently appear in the history of patients with intestinal obstruction due to fecal impaction are specific and identifiable. And most people in this situation right now will recognize at least two or three of them immediately. The first and most universal is chronic low-grade dehydration, not the obvious dehydration that produces intense thirst, but that silent dehydration where the body is functioning with less water than it needs so gradually that the sensation of thirst never arrives with enough force to signal the problem. When the body is chronically slightly dehydrated, the large intestine compensates by pulling more water than it should from the waste in transit, accelerating exactly the hardening process that creates impaction. The second factor is physical inactivity, because body movement is one of the main stimuli for peristalsis, which is the rhythmic muscular contraction that moves waste through the intestine. People who sit for long periods, who have reduced mobility, or who have gone through a period of prolonged bed rest are at significantly higher risk. The third factor, and this is the one that most often surprises people, is medications. Opioid painkillers prescribed for chronic pain have the documented side effect of dramatically reducing intestinal motility. Tricyclic antidepressants, anticholinergics, iron supplements, and long-term use of antacids have similar effects. If you are taking any of these medications and are facing this situation for the first time or on a recurring basis, this specific connection deserves a direct conversation with the doctor who prescribed them, because there are specific preventive strategies for each case that are rarely explained in the consultation where the medication is prescribed. The mechanism by which the situation progressively worsens while you wait is what most justifies the urgency to act now instead of waiting to see if it improves on its own. When a hardened mass is present in the intestine, it does not remain static. It continues to be dehydrated by the intestine as it continues its water absorption work, getting progressively harder and bulkier as new waste coming down from higher regions of the digestive tract accumulates behind it without being able to pass. The intestine, in turn, tries to compensate by increasing the force of peristaltic contractions in an attempt to move what cannot be moved, which produces the cramps and the feeling of increasing pressure that many people describe as the only physical sensation that finally makes them seek help. And every hour that passes without resolution is an hour in which the intestinal tissue around the mass is subjected to pressure that progressively compromises the blood circulation in that tissue, a process that, when advanced, transforms a problem solvable in an office into a problem requiring urgent hospital intervention. You have no time to waste thinking it will get better on its own, but you have enough time to follow the correct protocol. If you start now, this topic may be the most important of the entire video because the error I'm about to describe is exactly the type of error that transforms a situation solvable at home into a hospital emergency, and it is a completely understandable error that anyone would make without this specific information. The most dangerous and most frequently misinterpreted sign is the watery diarrhea that can appear even when there is a significant intestinal obstruction. You have had days of constipation, weight, and abdominal pressure, and suddenly you start having liquid, watery bowel movements. The immediate and logical conclusion is that the problem is resolving, that the intestine is finally working, that perhaps it's a stomach virus superimposed on the constipation. And the equally logical decision is to take an anti-diarrheal to control what seems to be diarrhea. Do not do this. What is happening is called overflow diarrhea, and it is one of the clearest signs that the obstruction is advanced. The hardened mass is completely blocking the passage, but liquid waste from higher regions of the intestine is finding small gaps around the mass and leaking through them. It is not diarrhea. It is the symptom of a blockage so advanced that the only waste able to pass are particles small and liquid enough to bypass the stone. If you take an anti-diarrheal at that moment, you will paralyze the intestinal contractions still trying to solve the problem, and you will transform a difficult situation into a critical one in a matter of hours. Another symptom that is completely confusing and that most people would never connect to the intestine is urinary difficulty. You may feel urgency to urinate but manage to pass only a few drops with significant discomfort, or feel that the bladder does not empty completely even after going to the bathroom. This happens because the rectum, distended by the mass, physically presses on the bladder, which is immediately in front of it in the pelvis, compressing it in ways that interfere with both the capacity to store urine and the ability to empty it completely. The complications that develop when intestinal obstruction is ignored for long enough are serious enough that I need to present them with the clarity they deserve, not to create unnecessary panic, but so you concretely understand why acting in the next few hours is categorically different from acting tomorrow or the day after. The intestinal wall is a living muscular tissue supplied by blood vessels that need proper circulation to maintain tissue health. When a hardened mass presses against this wall for days on end, circulation in the compressed tissue begins to be compromised. First, signs of mild ischemia appear. The tissue begins to lose structural integrity progressively. If the pressure continues, the ischemia advances to necrosis, intestinal tissue death, which is a surgical emergency requiring removal of the affected intestinal section. And in the most serious scenario of all, which is more common than most people imagine, the accumulated internal pressure causes an intestinal perforation, an actual physical tear in the intestinal wall through which toxic fecal waste spills directly into the abdominal cavity. The result is peritonitis, a massive, life-threatening infection of the peritoneum that requires immediate emergency surgery and prolonged ICU stays. I'm describing this not to scare you, but so you understand that the line between an obstruction resolved with suppositories at home and an obstruction requiring emergency abdominal surgery is a line that time crosses, not you. And this line can be crossed in a matter of days depending on how advanced the situation is at the moment you start to act. The good news, and it is genuinely good, is that if you are watching this video now and recognize the symptoms, you still have time to follow the correct protocol and resolve this without coming near these complications. The first instruction of this protocol is also the most counterintuitive, and it is the one most often ignored because it goes against the instinct of anyone in discomfort who wants to resolve the problem as quickly as possible. Stop straining completely now. Each time you force, you are further compressing a mass already hardened to the maximum, increasing pressure on already compromised intestinal tissue, and progressively inflaming the surrounding region in a way that will make every subsequent stage of the protocol more painful and difficult than it needed to be. The muscular effort you are applying does not have the physical capacity to move a mass of this density. The only thing it succeeds in doing is worsening the situation while you waste energy you will need for the next stages. With that established, let's go to the first real step: home intervention with adult glycerin suppositories, available without prescription at any American pharmacy. And here is the detail almost everyone gets wrong and which completely determines whether this intervention will work or not. You are going to use 3 adult glycerin suppositories simultaneously, not 1, not 2, 3. The reason is specific and physiologically grounded. A significant impaction in an adult requires a volume of lubrication and stimulation that a single suppository simply cannot provide within the available action timeframe before the product is expelled. The correct protocol is to lie on your side to remove downward gravitational pressure from the pelvis. Generously lubricate the 3 suppositories with water-based lubricant, even if they already feel slightly slippery, because the mass inside you is completely dry, and any introduction without abundant lubrication will be painful and counterproductive. And insert all 3 deeply, positioning them as close as possible to the hardened mass. Now comes the most important rule of the entire protocol, and the one most often violated because the sense of urgency the body produces feels impossible to ignore. You are going to stay lying on your side for a full minimum of 30 minutes without going to the bathroom, regardless of the urgency you feel before that time. The glycerin needs time to melt at body temperature, coat the surface of the hardened mass, and intensely lubricate the internal walls around it. If you rush to the bathroom after 5 or 10 minutes because you felt a slight urgency, you will expel the suppositories still partially intact, and the mass will remain exactly where it was, with the added aggravation that the surrounding tissue will be more irritated than it was before. If after the full 30 minutes you go to the bathroom and the mass still does not move, do not panic, do not restart straining, and do not take any additional medication without following the correct sequence. Get up, walk around the house for a few minutes to stimulate peristalsis through physical movement, and wait 1 full hour. After that hour, repeat the entire protocol. Lie on your side, lubricate abundantly, insert 3 new suppositories, and wait another full 30 minutes. Sometimes the first round only manages to soften the outermost layer of the mass. The second round provides the additional volume of lubrication and stimulation needed to finally dislodge the central core. If after 2 complete rounds of the suppository protocol the mass is still stuck, your home attempts must stop immediately. And we reach the third step. The third step is to go to the emergency room or an urgent care clinic, and I need you to read what I am about to say with all the seriousness it deserves. Do not let embarrassment stop you from taking this step. Hospital staff see this condition much more often than you imagine. It is one of the most common presentations in American ERs, affecting people of all ages and all backgrounds, and is treated with the same clinical objectivity as any other medical condition. In the hospital, the team will perform a professional-grade clinical enema using proper volumes of fluid and medical lubricants to break up the mass from the inside out with tools and techniques that simply are not available in a home setting. If even the hospital enema fails, and this happens in cases where the mass is particularly advanced, we reach the fourth and final step, which is manual extraction performed by a specialist in an operating room under deep sedation or spinal anesthesia to completely numb the lower half of the body. It is a serious procedure requiring proper recovery, but it is the only safe path to remove an obstruction at this stage without risk of intestinal wall perforation. And the immediate relief after removal, the instant drop in pressure, the disappearance of pain, the feeling that the body can finally breathe again, is something patients consistently describe as indescribable. But removal is only the beginning, because if you go back to the exact same routine that created the situation, it will repeat with a certainty no over-the-counter laxative will prevent. The first thing I need to tell you about prevention is also the most uncomfortable, and I say this with every intention of it being uncomfortable, because the discomfort of truth is infinitely preferable to the discomfort of a second impaction that could have been completely avoided. The most common habit leading people back to the ER weeks or months after the first episode is dependence on over-the-counter stimulant laxatives as a long-term prevention strategy. Stimulant laxatives work by chemically irritating the intestine and forcing artificial contractions that move waste regardless of the intestine's natural capacity to do that work. In the short term, they produce results that seem satisfactory. In the long term, they are actively destroying the intestine's autonomous capacity to function, because intestinal muscle, like any muscle stimulated artificially instead of exercised naturally, progressively loses the ability to contract on its own. After weeks or months of regular use of stimulant laxatives, the intestine has developed a functional dependence on chemical stimulation that, when removed, leaves an intestine completely unable to move waste autonomously. The result is more severe constipation than the original, leading to higher doses of laxative, which leads to deeper dependence, in a cycle that ends inevitably in a more serious impaction than the first. The real prevention protocol has 4 components that must be implemented together and maintained consistently, not for 2 weeks, not for a month, but as permanent changes in how you treat your own digestive system. The first is real and monitored hydration, not drinking water when you remember or when you are thirsty, but consuming a minimum of 2 liters per day, distributed throughout all the hours you are awake, starting with a large glass immediately upon waking before anything else. The second component is daily physical movement, and it doesn't need to be intense exercise to produce a significant digestive effect. A 20 to 30-minute walk per day stimulates peristalsis in ways weeks of laxative use cannot replicate because physical movement mechanically activates the enteric nervous system that coordinates intestinal contractions through a mechanism completely different from what any medication accesses. Studies published in the World Journal of Gastroenterology documented that sedentary adults who introduced moderate daily walking showed a significant reduction in the frequency of severe constipation episodes compared to control groups receiving only dietary guidance. The third component is dietary fiber, but with a distinction that can be the difference between fiber that helps and fiber that worsens. Soluble fiber, found in oats, psyllium seeds, beans, lentils, and fruits like apples and pears, absorbs water and forms a gel that softens the stool and facilitates transit in a smooth and predictable way. Insoluble fiber, found in wheat bran and processed cereals, adds bulk but requires much higher hydration to function properly. And when consumed without enough hydration by people with a history of constipation, can paradoxically worsen the situation by increasing waste volume without increasing its moisture. The distinction between the two types of fiber is rarely explained in generic guidance on constipation, and it is exactly this distinction that determines whether the dietary change will solve the problem or just change its appearance. The fourth component is training the evacuation reflex at a consistent time, because the intestine responds to patterns with an accuracy that is extraordinary when respected. Going to the bathroom at the same time every day, preferably 20 to 30 minutes after breakfast when the gastrocolic reflex is naturally most active, and sitting for at least 5 to 10 minutes regardless of whether you feel urgency or not, trains the intestine to prepare and execute evacuation at that specific time in a progressively more efficient way over weeks of consistency. The final component, and the most specific to ensure an impaction never repeats, is a specialized medical evaluation going beyond general advice, because there are underlying causes of chronic constipation that are medical, not behavioral, and that no amount of fiber, water, or walking will solve without treatment of the root cause. Undiagnosed or undertreated hypothyroidism is one of the most common. Reduced thyroid function directly decreases the speed of intestinal transit in ways that only improve when the hormonal problem is treated properly. Diverticular disease, affecting a significant proportion of Americans over 50, creates pockets in the intestinal wall where waste can accumulate and harden independently of general transit. Post-inflammatory intestinal strictures, narrowing of the intestinal passage caused by previous episodes of inflammation, can be identified only through colonoscopy and may be the cause of recurrent constipation that does not respond to any behavioral intervention because the problem is structural. If you have already had an intestinal impaction episode, regardless of how it was resolved, a consultation with a proctologist or gastroenterologist for investigation of underlying causes is not optional if you want to ensure you don't go through the same experience again. Do not let embarrassment stop you from this consultation. The alternative is waiting for the next episode, and the next episode will arrive at a time just as inconvenient, just as painful, and just as avoidable as this one. I want you to pause for a moment and think about what you just learned, not as just another list of health information you'll forget in a few hours, but as a complete map of a situation affecting your body right now that has a clear, structured, and immediately applicable solution if you act with the urgency the moment deserves. You understood how an intestinal impaction forms silently over days while you follow your normal routine thinking you're fine, how the intestine progressively drains moisture from accumulated waste until it transforms into a mass no muscular force can move. You understood why the watery diarrhea appearing in the middle of a severe constipation episode is not a sign of improvement but of advanced blockage, and why taking an anti-diarrheal at that moment is one of the most dangerous mistakes you can make. You now have the 4-step emergency protocol, from glycerin suppositories at home to hospital enemas and manual extraction when necessary, and you know exactly when each stage begins and when the previous one must stop. And you understand why stimulant laxatives that seem like the most convenient solution are exactly what will ensure you're here again in a few weeks, because they progressively destroy the autonomous capacity of the intestine to function while creating the dependence that keeps the cycle turning indefinitely. This information completely changes what you can do in the coming hours. And what you do in the coming hours determines whether you resolve this today at home or tomorrow in an ER in a much more advanced situation than it needed to be. Do not wait to see if it improves on its own. Do not wait until tomorrow. Start the protocol now. There is one thing I need to say before closing, and I say this as a doctor who spent years seeing people suffer unnecessarily because of a stigma that should not exist around a condition as common and treatable as this one. The embarrassment you feel about this subject is completely understandable, but it is hurting you. It is making you wait longer than you should. Try to resolve it alone when you needed help, and avoid the medical consultation that could have prevented the current episode or that can ensure there won't be a next one. Digestive health is not a minor subject or less worthy of attention than any other area of health. It is the foundation upon which all your energy, your mental clarity, and your overall physical well-being are built. An intestine that does not function properly compromises the absorption of all the nutrients you consume, raises systemic inflammatory markers, interferes with sleep quality, and affects mood and cognition through the gut-brain axis that modern neuroscience documents with increasing precision. Taking care of your intestine is not a health detail. It is one of the most important decisions you can make for the functioning of your entire body, and you deserve to have access to the information and specialized care that allows you to make that choice with real knowledge instead of shame and silence, which never helped anyone get better. Now, I genuinely want to hear from you. 3 questions to answer in the comments right now. First, out of the information we discussed today, the mechanism of impaction formation, overflow diarrhea as a sign of advanced blockage, the 4-step emergency protocol, and the distinction between soluble and insoluble fiber in prevention, which one surprised you the most? Which one had you never received with this clarity before watching this video? Tell me, because your answer tells me what still needs to be communicated with the most urgency to reach people who are suffering in silence without knowing there is a clear protocol for what they are going through. Second, have you ever gone through a situation like this and waited longer than you should have out of embarrassment? Write it here, because every person who shares this experience in the comments is helping to normalize a conversation that should have happened much sooner, and that can give someone watching right now the courage to seek help instead of continuing to suffer in silence. And third, where are you watching from? City, state, country, and how old are you? If this video was valuable to you, if it finally explained what is happening and what to do in a clear and non-judgmental way, share it now with someone you know who may be going through this and would never speak about it out of shame. Press the like button. This helps this channel reach more people who need this information. Click subscribe now and hit the bell so you don't miss any content like this. And to continue on this digestive health journey, be sure to watch our next video where I reveal the 5 signs the intestine sends weeks before a serious obstruction that most people ignore completely because they don't seem urgent enough to deserve attention. They are. Take care of your intestine. It works for you every day without asking for anything in return, and it deserves the care and attention you just started giving it today.